Good morning, good afternoon, good evening to everybody all over the world. It's really a unique pleasure, by definition, to be with all of you at once, all across the world. This is a wonderful opportunity for me because I actually feel unbelievably passionate about the universal health coverage, as do most public health practitioners who've been advocating for access to care for all since 1948, basically, when the WHO proclaimed it, the UN in its Declaration of Human Rights, and specifically more recently, 1978, the famous Alma Ata Declaration had health for all, healthcare coverage for all people as its main motto, and yet we have not yet achieved it. Let me see if I can drive this. So this is a discussion first with me and then with your local experts on universal health coverage. I will be specifically focusing on primary health care, not tertiary or referral health care, and I will focus more on low-income setting. And the reason for that, the reason I'd like to focus on healthcare for all in low-income setting is that here we are in 2014, and there still are 1 billion people who live and die in absolute extreme poverty, and 6 million children that die every year, and 500,000 pregnant women die every year. And all of this is from preventable and treatable causes. I'm sure you've all seen this, but I wanted to show this life expectancy graph, which shows the, for me, unacceptable discrepancy in the world, which is that the life expectancy in places like sub-Saharan Africa is a good 15 years lower than it is in the rich countries. And most of that is dragged down, the lower life expectancy is dragged down by the child mortality. So what I would like to discuss with you over the next 45 minutes is how one can establish primary health care in very remote, rural, low-income areas. I would like to first discuss with you the excess disease burden, and then I would like to try to convince you that actually it is within reach, that we actually can provide at very low cost a very high impact primary health care that does cover all people, especially the ones that are usually left behind. So I'd like to discuss some of the system components, and then I'd like to introduce some novelties that may not be so novel to you anymore, but that the Millennium Villages Project has developed, which makes the health systems actually a reality within reach. And then I'd like to discuss a little bit of the cost of universal health coverage, although for that I would prefer if my in-house economist were here. I am sure you all have seen this chart, the burden of disease by groups in regions in the world. To me, this chart is just the most important thing that summarizes the situation of healthcare in low-income setting. So as you see on the x-axis, it's the different areas of the world. On the y-axis, it's the DALYs, the disability-adjusted life years, which looks at how much life has been lost to either death or to disability, a severe disability. If you could just look at the top two bars, because they sort of are the two stark bars that tell the picture. First, you'll notice that the high-income world, the bar is less than a third of the bar of the Africa column. So the disease burden in total is a fraction in high-income world than it is in Africa. So then when you look at the different kind of diseases that make up this difference, it's also shocking. in this case, it's indicated in the 3 different colors. The dark blue, the so-called group 1 diseases, are communicable and maternal diseases. That group consists mainly of death of newborns and mothers during childbearing, and it also includes the deaths from AIDS, TB, malaria, pneumonia, diarrhea, worm infestations, and immunization preventable diseases. So the dark bar, the dark blue, the bulk of it are these 3 components, which is infectious diseases, maternal death, and newborn deaths. The lighter blue is so-called group 2, are the non-communicable diseases, which, if you notice, are pretty much the same size in the high income as well as in Africa. And that's because people everywhere die of heart disease, neurological disease, etc. And then the lightest bar, which is basically injuries and accidents. So the striking thing about this picture is that there is an excess disease burden in Africa, and that the bulk of it is in preventable and treatable category, the so-called category 1 disease. I'd like to quickly just show you that all of those, if I could go back to the bar graph. To me, this bar graph shows that given that the group 1 diseases are no longer a problem in the high income country, because as you see in the top bar, it's just a sliver. The fact that it's basically not a problem in high income countries speaks loud and clear that those diseases are obviously things that can be addressed and dealt with. And so that's why we focus on the group 1 diseases, because they have already been proven to be addressable, and therefore it behooves us to do so. I just want to quickly show you the causes of death and the interventions that have been well proven, well documented, and by the way, beautifully published by a series in the Lancet Infectious Disease Journal over the first 10 years of this century. So up till about 2008 or 9, the Lancet has documented scientifically proven, evidence-based, non-controversial interventions that exist to address all of the causes of death that I just enumerated. Pregnant women die of basically only about 5 treatable and preventable things during pregnancy and delivery. 1, unsafe abortion or unwanted pregnancy. 2, eclampsia, which is basically high blood pressure, treatable but fatal if not. Complications during delivery and obstructed labor, during delivery such as obstructed labor, excessive bleeding, and infections after delivery. So it's just these 5 common horrendous causes of death, and they are preventable by basically having 3 components in the health system: family planning, so that a woman can decide when she does or does not want to get pregnant, safe abortion if necessary, antenatal care, and institutional delivery. Institutional delivery consisting of having a skilled birth attendant, not a traditional birth attendant or your mother-in-law, but a skilled birth attendant and an emergency referral system that's operational 24/7. When you look at newborns, they die only basically of 3 main categories: prematurity or low birth weight, being mature but underweight; birth asphyxia, related to trauma of the birth, if it were, for instance, an obstructed birth, and newborn infections. So horrendous death burdens, but by 3 preventable conditions. And again, the interventions that are very well described in the protocols in Lancet are, again, antenatal care with counseling, institutional skilled birth attendants, and then postnatal care. And children die of about 7 main diseases that, again, are imminently treatable and most of the time even preventable. So birth, I already mentioned. The second is malnutrition. where, of course, the availability of food, the diversity of food, clinics, CHWs, deworming, vitamin A, screening for nutrition and malnutrition, all of these interventions are known and play a major life-saving role. The third is diarrhea, where prevention is, of course, sanitation and hygiene, which is much easier said than done. Treatment is, as you all know, is oral rehydration solutions and zinc. And then malaria, a major killer in sub-Saharan Africa, which is really preventable by the long-lasting insecticidal bed nets, if they cover every sleeping site. And then malaria is now, recently, last 5 years, screened by a rapid diagnostic test at the household, does not require a clinic, electricity, a microscope, a laboratory person. It's just a community health worker who can do a simple rapid diagnostic test at the household level, and then has the ACT, the artemisinin combination therapy, to treat the malaria. Pneumonia, again, somewhat preventable, because a lot of it is contributed to by the indoor air pollution, by the cook stoves that people use in Africa. And pneumonia is also eminently treatable and can be even treated by a community health worker. Measles, preventable by vaccine, and AIDS, which I think you will discuss at another time, which is at this point, a disease that can be prevented and certainly treated. So the bottom line of what I would like to leave you with is that we know the epidemiology, we know the disease burden that causes this unacceptable difference in deaths and disease in the world. We know the interventions very clearly described in scientific journals. What we have failed to do is to be able to deliver these at scale. There has been one a huge boost to this, and the one big exception, which is in 1980. You may remember, some of you may have read that the UNICEF leader then, James Grant, was a visionary and really revolutionary, I would say. He promulgated something called the Child Survival and Development Revolution. It was sort of a major, one of a kind vertical program at scale to deliver 4 things: growth monitoring of children, oral rehydration for those with diarrhea, breastfeeding, exclusive breastfeeding for 6 months, and then continuing breastfeeding up to 2 years of age, and universal immunization. These 4 things brought in as a vertical program, a campaign style program, hugely impacted on child mortality. It really decreased child mortality substantially, and mainly probably by increasing immunization from roughly about 20% prior to this program to 80% after. So certain interventions have been delivered at scale and have been impactful. What is lacking, and what I would like us to focus on, and it's what we focus on in the Millennium Villages project, where we're learning and showcasing and documenting, is the delivery of a complex system but at scale, as opposed to one-off interventions once or twice a year. You probably know this history because you've been reading about this. I saw it on your reading list, which is this last 10, 14 years really have been seminal in thinking about scaling up. The first thing that happened, as you may have already read or heard, is the WHO Commission on Macroeconomics and Health in the year 2000 really turned things around for public health, because until then, we public health practitioners have been basically told that there is only a very small amount of money, and go ahead and see what you can do for the population for this very tiny amount of money. You understand the government doesn't have money, the country is poor, so just please make do. This was what was turned around by the WHO Commission, because the WHO Commission, first and foremost, promulgated that health is a precondition to development, as opposed to the other way around. Wait until the country is better off and has a higher GNP and stands on its feet, then maybe they'll be able to address their health system. This has turned that argument completely around, saying health is a precondition for development. And then it turned around another question that used to just irritate those of us who cared hugely, which is, instead of asking the public health community, what can you do if we give you $1 per capita? If we give you $1 per person per year, what can you do? And we were all scrambling. Should it be immunization? Should it be deworming campaigns? What should it be? And the commission, again, turned this around. Instead of asking, what can you do for this tiny amount, arbitrarily tiny amount of money, it asked the following question: what would it cost to address those category 1 diseases that I showed you before? The category 1 diseases being, again, basically malnutrition, infectious diseases, and childbirth. What would it cost? And it set out with 200 some public health and economists, and costed it out at the time, and this was in year 2000, costed it out to be $34 per capita. So they stipulated that $34 per capita could really make a robust, simple, but core health delivery that would address these problems. $34 per capita in the year 2000 was about an order of magnitude more than what most countries in sub-Saharan Africa were spending. Then, of course, you all know the deservedly famous MDGs did a huge thing for us, because when they were adopted in the year 2000, it really focused everybody on the goals, on the quantifiable measurement. And for me, what it really did is present the holistic approach, that you no longer talk about the one magic bullet for poverty, but that you talk about the need for health, education, infrastructure, etc. So it was a holistic, quantifiable, and goals. The Lancet series, unbelievably important set of tools that, as I said, described the interventions that existed. So we did not have an excuse. Well, children die, but we don't really know how to deal with it. The Lancet has become sort of the Bible on this. And then, of course, you know, the major scale initiatives such as by Gates, hugely impactful public-private partnership, of which Gavi, I think, was the first one, Global Alliance for Vaccine Immunizations, tremendously impactful. Then the Global Fund to Fight AIDS, TB, and Malaria. And then if you haven't yet, I would recommend that you read the 3 documents that I have on my PowerPoint: Disease Control Priorities in Development Countries, Human Resource for Health, and the UN Millennium Project. It is on the basis of that that we at the Earth Institute started the Millennium Villages Project in 2005. And it was, at the time, unfortunately, sort of the only project that tried to look at evidence-based approach, but also a systems-based approach to addressing poverty, including addressing the disease burden. And from that, we've also been, many people in the world have been joined to consider community health workers, professional community health workers, as a major pillar of the health system. No. Must be Jeff checking on me. So I wanted to point out why the health systems approach is so important. Maternal mortality, in fact, has dropped by 50% since 1990 to 2012. But in order for it to get to where we need to get by 2015, it would have to drop again just by half in the next year or two. In other words, maternal mortality has dropped, but by no means adequately enough to meet the goal. Child mortality has also dropped hugely, and I would repeat that the main component of the decrease in child mortality, in fact, was due to what UNICEF did, these vertical programs delivering 4 life-saving interventions for children. However, as you notice on this graph, which plots on the y-axis, it plots the deaths per 1,000 live births, the child mortality, which is always reported per 1,000 live births. And on the x-axis, you have the years up to about 3 years ago. The thing that you notice is that the child mortality, in fact, which is the overall bar, the child mortality, in fact, is going down, but thank God. But number one, not fast enough to meet the MDGs. And number two, what you notice is that the newborn mortality, which is newborn, by the way, is defined as a child, right, from the second of birth to 1 month of age. So the newborn mortality, you'll notice, which in 1990, which is at the very beginning of the graph on the left, newborn mortality was about a fifth or so of the total child mortality. And as the child mortality has been addressed successfully by mainly the vertical programs, the newborn mortality, which has not been addressed by these vertical programs that come in once a year, campaign style, the newborn mortality becomes proportionately a bigger portion of the total mortality. So the decrease has not impacted, the decrease in child mortality has not impacted on newborn deaths, which are still unacceptably high. If you look at the graph on the very right, you see that the newborn deaths are now a large proportion of the total death. And I made a little arrow to show you that actually, if you look at the first 2 years of life, that's where the bulk of the deaths take place. And therefore, since we now know that the maternal mortality is all about pregnancy and delivery, and that child mortality is mainly about what happens during birth and the first month of life, and that the overall child mortality really is what happens during the first 2 years of life, that's why I would like you to look at this slide, which basically summarizes it as the 1,000 days during which we can make a huge difference. The 1,000 days is a concept stolen from the nutritionists who have championed this for many years as the time to intervene for proper nutrition, which is pregnancy and then the first 2 years of life. So in a way, this looks like a huge opportunity. You have just a very small window during which you can make a huge impact on saving lives. So you think it's a great opportunity because it means that if we can get it right, just during this short period of time, we can make a huge difference. However, the problem is, oh, and by the way, to make that point even more stark, it's not only what happens during the first 1,000 days, it's actually what happens during the first month of the child's life, and within that, it's actually what happens during the day of delivery that's hugely impactful. So if we could get it right on the day of delivery, imagine there's this unbelievable opportunity that if you could get it right on the day of delivery it would really impact on 2 lives, the mother's and the newborn, and then the lives of those that, if the mother dies, the lives that it impacts by having the mother herself die. So it really is a stark realization that it's 1,000 days, 1 month, and actually 1 day. What is the problem then? Why don't we just take care of it since it's such a identifiable moment? Because this cannot be addressed by any shortcuts. This cannot be addressed by campaign style interventions. This cannot, even if you perfect them, this really requires a system. So on the bottom of this graph, I showed you that even though it's really basically just 1 day that we have to get right, look at how many things have to be in place in order for that to work. So first, the pregnancy has to be a wanted pregnancy to a healthy woman. So family planning, antenatal services, clinics, nutrition counseling, etc. Then the woman has to have telephone or some way of alerting that she is about to deliver and can't walk to the clinic. So you need some sort of telephony, roads, transportation that's summonable within a few minutes. Then on the day of delivery, you actually need a setup in a clinic, what's called a basic emergency obstetric care. You need a clinic within a very short walking distance of every household that's open 24/7, has a skilled birth attendant always available, and that the skilled birth attendant, in addition to knowing how to deliver the baby, also knows how to resuscitate the baby, which has now been reduced to very simple 3 steps, that anybody can do, even a person who's not literate. So what that requires is a midwife in place 24/7 and reachable within walking distance. And then all of that comes with having a clinic. You need a supply chain. You need the training for the midwives and the community health workers. You need an informatics system for information flow, management, financing, the outreach that I'd like to talk about a little bit later, because although the critical thing happens in the clinic, it's what happens before and after the clinic that's important. Is there a community health worker who encourages and helps the birth preparedness for the woman to go to the delivery? Is there a community health worker checking on the newborn the first week of life? And then you also need a referral hospital for those women who actually cannot be delivered by a midwife because they actually do need an operation. And so you need an immediate emergency transport communication and transport system to go to a referral hospital. So in fact, there is an opportunity to really make a huge difference in the unacceptable child and maternal mortality, but it's not a one-off shortcut, quick and easy solution. In this graph, what I've shown is that under service packages are those three things that I told you constitute the Category 1 diseases: the safe childbirth, nutrition, and prevention and treatment of childhood infections. And we know how to address those interventions, as I kept saying, we have. But then what you need is what's on the left side, the delivery system. And that's what really has not been paid attention to, and certainly not in low-income setting. And the delivery system is, of course, the campaigns, the vertical campaigns do play a role, but they're necessary but not sufficient. It has to consist of community health workers, clinics, hospital, the referral system. And then the health system also requires management, infrastructure, equipment, drug supply, training, supervision, accountability, empowering the community to enunciate its needs. It needs data, and in the Millennium Villages, I'll show you, we actually insist on real-time data, not just for the usual monitoring and evaluation, but for actually improving the management of the system. And then it requires, of course, financing on the national scale and the policy environment. So I just quickly wanted to show you the newborn and maternal mortality in more detail, because as you see, the newborn and maternal mortality really is kind of a quick and easy indicator, a very sensitive indicator of the strength of the primary health system. Because for a newborn and mother to survive, you really need this continuum that's in place rather than having sort of periodic interventions. And it is this basic primary health system that we are learning about, piloting, showcasing, and documenting in the Millennium Villages project. Really quickly, in the Millennium Villages project, we are modeling this health system. If you can see this slide, we started at $40 per capita. This is now 10 years ago. $40 per capita to deliver a free point of service care. In other words, the healthcare isn't free, obviously, it's costs money, but it should not be paid at the point of service, i.e. it should not be paid at the household. The clients should not be asked at the household when they're seen by a community health worker, nor should they be asked at the clinic. You all remember the movie that we saw that Professor Jennings showed us a couple of weeks ago, where in Malawi, the movie starts with a woman holding a baby, breastfeeding, and discussing her life. And then later on in the movie, she's sitting there again, but no longer having a baby. And she describes how that baby died because she actually did do the right thing. She did go to the clinic. The clinic actually had what it takes. But unfortunately, she did not have, as she says in the movie, very movingly, she did not have enough to get the right kind of medicine, and the baby died. So free at point of service is a sine qua non of universal healthcare coverage. And then what do you need to know and set up for sort of local health system? First and foremost, you need to know the burden of disease. So you need to know your epidemiology. In sub-Saharan Africa, I showed you what that looks like. You need to integrate health interventions with non-health interventions, because it's no good to save a child's life at birth when that child then goes home to a mother who has absolutely nothing to eat. So food security, education of the mother, water access, etc., all play a big role. So health system cannot thrive in a vacuum. The health system, that we're deploying in the Millennium Villages is what they call a continuum of care system, or close to client system, where each household has an identifiable community health worker. One community health worker has about 100 or so households, and that community health worker is paid and held accountable, trained, managed, supervised, retrained, and mainly held accountable for the well-being of that household. The community health workers are then connected, as well as the households, to a clinic. So in our model, there has to be a clinic within 2 hours walking distance, no further than that. So that means a huge amount of additional clinics had to be built. The clinic has to have a skilled birth attendant. That's a sine qua non of a clinic. Clinic is not a clinic unless it can do safe maternal and child delivery. And then there has to be the referral system, where I have the little arrow for ambulance. The one important component that I will discuss a little bit later is that this health system has to be infused with data flow that informs whoever is in charge, the health coordinator of that area, has real-time data about what's going on and what needs to be attended to. I do want to dwell a little bit on the community health worker profession, because it is something that the whole public health community, international public health community, has realized really is a critical component in this health crisis, where there isn't enough funding, and therefore there isn't enough professional doctors and nurses. And it turns out that community health workers, which are community villagers, people living with the other villagers who are literate, but however do not need any additional preconditions. The community health workers, we think, are incredibly important. However, in the Millennium Villages project, we have shown that they really have to be stepped up to become not volunteers who happen to work when they happen to have some time in between harvests, whatever, but that they have to be full-time, professional, paid, supported, managed, and held accountable community health workers who, at this point, it's a well-known fact and demonstrated in other places, not just the Millennium Villages, can actually do a lot of preventive and promotive care, but they can also do a lot of therapeutic care. Due to this new test, the rapid diagnostic testing, the family of the child can be treated at the household because we can actually detect whether or not there's malaria, can be treated at the household. Same with diarrhea, same with pneumonia. So the community health worker really has become a critical component and a major pillar, which we at the Earth Institute and many other organizations have gotten together in a 1 million community health worker campaign to advocate that there be a rapid deployment, rapid scale up of trained community health workers in all countries in sub-Saharan Africa that are interested in having it. And by the way, Guinea, the country of Guinea that now, of course, is ravaged, along with Sierra Leone and Liberia with Ebola, has asked us, the president has asked the Earth Institute, and we're in the process of gearing up with the help of Dr. Dillon, who's also here in the audience, to address the Ebola emergency. In addition to the treatment that has to happen in the clinic, which obviously needs to be strengthened, but also to use this community health worker force to actually really finally start to stop the transmission of this virus by being in the community, detecting very early when there is a case, trace the contacts of that case, alert the specialists about where the case is, etc. It, by the way, saddens me tremendously that Liberia, a year ago or a year and a half ago, has asked us to, and we did deliver at the Earth Institute, a plan for national scale of community health workers, which for a small country is actually quite inexpensive. And we shopped it around to all the usual donors who said, yeah, well, that would be very nice, but we don't have those couple $1 million. And of course, now we're all beating ourselves, because if Liberia had this network of community health workers, it really would have been a different story. And we're retroactively trying to catch up, at least for the moment in Guinea. Why so much emphasis on community health workers? As I was saying, it's basically a financial problems that they're much less expensive. They are impactful. It's been proven they're impactful in child mortality. They're quickly deployable. They're less likely to brain drain out. They're more likely to stay in the community. They come from the community. And in addition to their relative advantage to other health workers like nurses and doctors, they also have an absolute advantage. I think community health workers actually are a very important component, even in a rich system, health system like in the United States. And there are colleagues who are actually working on that here in Harlem, because it turns out even if you have a state-of-the-art clinic and referral system, there still are households that either do not avail themselves of those institutions, or who actually would do well if they had a counselor who outside at their home advises them on nutrition and other life skills. The community health workers, as you all are aware, have recently been really empowered by what's called mHealth, which is using mobile telephone for health. And that's really changed everything, because now the community health worker, first of all, has the phone that can help him or her at the household level. At the household level, but it also is a very powerful tool to gather data. In the Millennium Villages, we've set up an application called ComCare, along with Dimagi and some other organizations. And ComCare on a smartphone is a way that you can use data to both manage the healthcare workforce, the community health workers, and also improve the quality of the care. So the ComCare on the smartphone is able to deliver three things. Number one, it can help, of course, the community health worker deliver better care at the household. Two, it gives the manager, who then gets these results or sees the data from the phone, it can help the manager better track the work of this a community health worker, and so can really keep track of productivity, et cetera, and hold the community health worker accountable. You know, why is it that I only see one visit yesterday when you work all day? And then a third service that this provides is it gives data for public health training that you can use to not only manage the workforce, but you can use it to adapt the implementation. If you notice that there is an sudden increase in child mortality in a particular area, not a year or two later, which is how it comes out now, but a week later you find that out and you can actually respond to it and address it. You don't have to look at these. I just wanted to show you that in the Millennium Villages, thanks to this, very easily trained on, very happily used by the community health workers, smartphones with ComCare gives us a whole slew of indicators, which really gives a rich data set to be able to have the community coordinator, the local person, really manage the health system. And it also gives us, who are far away, a wonderful day-to-day vision of what's happening. And it sort of gives four main categories of indicators. One is the coverage. How many households has the community health worker seen? How many pregnant women, etc. The second one is quality. Okay, so the health worker did see a child with fever. Did they do the rapid diagnostic test for malaria? If the rapid diagnostic test was positive, did the community health worker give the malaria drug? If the community health worker gave the malaria drug, did they come back 2 days later to check on how the child is doing, etc.? So the quality of care. And then, of course, it gives us outcomes, which is we collect vital events, births and deaths. And also it gives another opportunity, which I would like to discuss for a moment, which is something that we've innovated in the Millennium Villages, which is called verbal autopsy, or I call it verbal social autopsy. And what that is now that the community health workers are in charge of 150 households, they certainly know when somebody is ill and hopefully is right there to take care of it. But when a person dies, they are immediately to report it, and they are immediately to do a very short questionnaire of the next of kin to find out what most likely was the cause of death. You know, was it an accident? Was there fever, cough, most likely pneumonia, whatever. What was the most likely cause of death? And then the so-called social autopsy. Okay, so the family noticed these symptoms. What did they do? Was it their decision not to seek care, or they did seek care but couldn't find the community health worker, or they did get the community health worker but they didn't have a way of getting to the clinic, or they did get to the clinic but the clinic was closed, or the clinic was not closed but there was no nurse there, or the nurse was there but she didn't have the drug that she needed, et cetera, or all of that was in place but the nurse wanted to refer them to a referral hospital because it was an obstructed labor. She can't handle obstructed labor, she can't do cesarean section, she wants to refer them but the ambulance is not available. So this is asking next of kin. Okay, so these are the symptoms, most likely it was malaria or pregnancy, whatever, and then trying to find out where the gap in the system went. And it's hugely impactful in that it gives us in real time, it gives them, the health managers, information where the gaps are and how to improve it. So in summary of this part, I still have a little bit more that I'd like to harangue you with, but it is within reach that we can hugely decrease child mortality and maternal mortality, and we can actually fulfill health for all, especially the most vulnerable. But it's not on the cheap and it's not quick and easy. I'm trying to convince you that it requires a focus on comprehensive, holistic approach. It has to be a local healthcare delivery mechanism, a systems approach, so evidence-based interventions, but a systems approach. I'd like to make a special pitch for professionalized community health workers, and also for reminding all of us that there are now technologies like the smartphone and many other things like the rapid diagnostic test, technologies, protocols, tools that actually make this possible. And then this real-time data, which is uniquely doable now given the mobile telephony, and it's really a game changer. What is the cost of what is the cost of universal health coverage? So this is when I want to remind you that in the Millennium Village Project, we started with what the WHO Commission on Macroeconomics and Health recommended, which is they said at the year 2000, $34 per capita, that you need $34 per capita to have a health system. In 2005, we adjusted it to $40 per capita. So the whole health system that I showed you before is for $40 per person per year. This is compared to what, $7,000 in the US. The WHO now, that it's 2014, recommends actually $60 per capita, which is much more reasonable. But we're still in the Millennium Villages operating under $40 per capita. So even though it's 40 as it is in our case in the project, or 60 as the WHO recommends, very inexpensive, life-saving operation for a health system, but it's not at all within the reach of many countries in sub-Saharan Africa. So although it's only $60, countries in sub-Saharan Africa and other places in East Asia and Central Asia cannot afford it. I just want to go through this little exercise to show you how much health spending can a country in sub-Saharan Africa afford. I took Ghana kind of as an example. The gross national product, the national income in Ghana, is about $500 per person per year. Domestic revenues, taxation that can bring the revenues to the government, is usually around 20% of that national income. And then once the government has this national revenue, it is their mandate to spend 15% of that. And it's been mandated by the Abuja Declaration in 2001. And not many countries are adhering to it, but it is a mandate, a moral mandate, that the government spend at least 15% of the budget on health on health systems. So in Ghana, that turns out to be about 3% of the GNP, which is about $15 per capita. So Ghana, even under optimal revenue collection, and even if they do abide by the Abuja declaration of 15%, that would give them $15 per capita. And I'm arguing vociferously that you cannot have a self-standing, self-respected health system for less than 40. WHO says $60 per capita. On the other hand, lower middle income countries are at this point able to do it on their own. So for instance, I didn't name this country. Yeah, Morocco or Honduras, middle income countries like that. First of all, they raise 25% of their gross national product in taxes, in their revenues, and 15%, if the government spends 15% of their budget on health, which would make it 3.75% of the GNP, then that would give a country like Morocco $70 per capita that the government can spend. And then I would argue that country does not need external aid for its health budget, really should be able to establish these simple rural health systems on its own. I wanted to just remind you, because there are many skeptics among us who say external aid never works, and I just wanted to give a tiny reminder that, you know, the malaria bed net story has absolutely debunked that, in that the Global Fund has focused on making sure that everybody in malarious regions sleeps under a bed net, and it didn't ask whether the country can afford it, whether the household can afford it. Mosquito insecticidal bed nets have been given out for free in all countries that have come with reasonable requests to the Global Fund, and malaria deaths are thank God decreasing. Same story with HIV/AIDS that you know very well. So I'm not sure what time it is, but I would like to conclude with the following sort of 10 commandments. With all of the work and experience that Jeff and I and Ranu and others and Glenn Denning have in the Millennium Villages Project, within the health, we have these following 10 commandments that we think are, that we're advocating for vociferously, because we think are critical going forward. So first of all, the world should, and is starting to, finally commit to a goal of universal health coverage. As obvious as that may seem to you, this was only a victory barely won recently, and now it actually is the WHO commitment. And universal health coverage has to be within the next set of goals, which are the Sustainable Development Goals, and I hope they will be. The rich countries should devote about 0.1% of their rich gross national product to help poor countries whose budget does not yet give them the opportunity to pay the $60 per capita. And I would argue that most of this external rich country philanthropy should not go into one-off projects, but should go through a pooling financing mechanism like the Global Fund, which many of us are advocating should become not the Global Fund for AIDS, TB, and malaria, but a global health fund. We absolutely advocate and counsel governments in low-income countries that they need to fulfill the Abuja commitment of allocating at least the 15% of their revenues to public health. So in other words, they should have at least roughly $50 per capita per citizen for health systems. The world should at this point adopt a plan, not just for malaria control, which is already ongoing, but we should absolutely commit to ending malaria mortality. Can't end malaria per se, because that's a much more complicated story, but we absolutely do have it within our hands, and we're learning and showing what can be done in the Millennium Villages, where you can really end child deaths from malaria. And I propose that we really focus on that as a goal over the next 2 years. And again, my in-house economist calculated that it would just take about $3 billion per year for all of sub-Saharan Africa to be able to eradicate deaths from malaria. Of course, the G8 countries should fulfill their commitments that they have committed to many times over for universal access to antiretrovirals. The world should fulfill the global plan to stop TB, which too is about a $3 billion financing gap. The world should fulfill its commitment for having women have access to sexual and reproductive health services, including emergency obstetric care, contraception, and this should be done now. There's no more planning for the future. This has to happen now. And we stipulate that it should go partly through this pooling mechanism of the Global Fund and partly by UNFPA. And then there are many people led by Peter Hotez and others who advocate that the neglected tropical diseases need to be addressed because they're actually quite easily controlled and by these mass campaigns. So it doesn't even rely on a health system. Mass campaigns, it's cheap, effective, and impactful. And as I mentioned before, the Global Fund that exists now should really establish a window for health systems and should really take on this community health worker approach. And the last thing is the universal health coverage has to eventually include also non-communicable diseases. We focus so much on the other diseases, the category 1 diseases, because as I showed you, they're disproportionately burdening the people in low-income setting. But after all, the non-communicable diseases burden them too, just not disproportionately to the rich countries. So all over the world, we need a strategy for oral health, eye care, mental health, cardiovascular, metabolic disorders like diabetes and obesity, and also behavior change that promotes just general healthy lifestyle, like healthy diets, physical activity, and cities designed for a healthy living, not the sprawling car-based cities. So the goal for universal health care coverage or health for all is really within our reach. The most critical thing is that there's no fee at point of service. It's been proven beyond shadow of a doubt that any even small fees at point of service is a killer for mothers and children. There should be no fee at point of service for at least women of reproductive age and children. And that this health system has to focus first and foremost on the most vulnerable in the society. And I also wanted to make the point that, let's see if I can do this. The green?
Yeah. Oh, no, just the cancel. Cancel.
Cancel?
Yeah, you were on it earlier. Cancel.
I'm sorry. Where, can you show me? That cancel. Sorry. I wouldn't listen to a person lecturing on universal health coverage if that person doesn't know how to click cancel, but you're stuck. So I just wanted to make a plea for all of us to read about, learn about, advocate for universal health coverage. My point being that we now have enough experience, we globally have now enough experience and enough evidence and enough data to show that it's feasible, doable, and that it's affordable. So thank you for listening, and I would be glad to see if I can answer some questions, and if not, I have my colleague, Dr. Dillon here. One question by Camilo is saying, universal health coverage is promoted throughout the world by, sorry, where is it? Oh, is promoted throughout the world by measuring the number of people that have access to health services. But what about health service quality as a development indicator? Is coverage enough? Excellent question. And pointing out, obviously, that this person knows a lot about health services and the history, in that many of the indicators have, in fact, been counting things that are relevant, but that actually don't show the ultimate impact. And so quality of care is unbelievably important. And so I agree with you, Camilo, and I just want to remind you that personally, or the team that works with me on the Millennium Villages project, we're very much looking at the quality of care, which is why, for instance, one of the innovations is this verbal autopsy. We are not just counting who died and who didn't die. We're actually looking into what happened. Was it a malpracticing community health worker? Was it that the nurse really doesn't know how to deliver babies? So there have to be indicators for the quality of care, and we've spent a lot of time thinking about them and including them. And I agree with you that that has to become a globally, universally accepted set of indicators on quality of care. Sorry, where do I click in order to make it blue?
Just click select.
Select. Because the question says, or this comment, because it is much more lucrative for big pharmaceutical companies to find cures than make vaccines, there is less investment in the latter. How can big pharma be encouraged to prevent outbreaks rather than cure them after so many lives are lost? Tanya is asking, and I of course completely sympathize. I would just expand the question that it's not just the pharma that should be encouraged to prevent reacting to outbreaks. It should be all of us. It should be the public health community. It should be what we tried to do with Liberia, where we were saying, please, let's at least spend a few $1 million to make sure that there is a network of community health workers, so that if something happens, first of all, it delivers care in the meantime, and also it's there in case something happens. So your question is right on. Pharma, of course, does exist because of its cost recovery and profit making. So I would not personally hold them responsible for that. I would hold the politicians and the policymakers responsible for setting the circumstances such that the pharma can do what they can do. So for instance, the pharmaceutical industry, they have, under a lot of pressure, but they have actually finally done what I think is very important, which is that they segmented the market. So for instance, when finally HIV was being addressed by treatment, not just sympathy and bereavement, which is what we were doing until recently, the pharma didn't give away the medicine because that is their livelihood, but what they did is they gave it at cost. And I think that's a huge distinction to make, and an important one. So it was, even though they sold it for $10,000 per person here in the US, they're selling it to the Global Fund or whatever at cost. So they don't make any money on it, nor do they lose any money on it. And then it's up to the policy of the WHO and the World Bank and others to figure out mechanism by which we can help those countries that can't still afford even that much lowered cost. So I think both the pharmaceuticals, but also the policy, the agencies like WHO and World Bank and others have to do their part to be able to set up systems that then actually encourage prevention and promotion of health, rather than just jump in as we're doing now when disaster hits and all of a sudden we need huge funds of money. You said select. I'm educable. Mr. Sachs said that it's very difficult that a poor country can afford a health system. What kind of experiences you have that could be relied on in low-income countries to find universal coverage? Yeah, this is exactly, Francisco Jose, this is exactly the kind of question that you're asking that has consumed most of 10 years of my life, which is exactly this. There are poor countries for all sorts of reasons that we don't have time to go into, not all of them because of corruption or mismanagement, but of course that too happens. But poor countries at this point cannot afford to set up health systems on their own, as I showed the distinction between low income and middle income. And therefore, I think it's our moral obligation. And more importantly than a moral obligation, it's very easy for us in the rich world to help support the funding for health systems in low-income countries until such time that their population is healthy enough, becomes more productive, therefore have a broader base for the government to tax from, and the budgets will then be able to do it on their own. So I absolutely agree that there are certain countries that still need additional help, and there's plenty of evidence to show that it works when it's targeted. When it's monitored, like it is with the bed nets or with the HIV, when it's a targeted, monitored intervention or funding for that intervention, it's really money well spent. Amelia is asking, how can necessary global health initiatives continue to function with changing political climates of global leaders and funders? For example, the withdrawal of support for family planning, abortion in developing countries under Bush presidency. Absolutely fair enough. As far as I'm concerned, I'm a pediatrician first and foremost. As far as I'm concerned, health and the access to health is above and beyond politics, policies, and ideologies. So as I tried to show in my presentation, access to reproductive health so that the woman is pregnant when she wants to be, is pregnant when she is secure that she can take care of this baby, as opposed to it being the 7th baby a year after her 6th baby, and she doesn't know how she's going to feed that baby or spend any time with that baby or send that child to school. Having a woman choose when she wants to get pregnant and what to do in order not to get pregnant when she doesn't, this spacing is a critical human right. And I would argue sort of the opposite of what the usual discussion is. I would argue that actually forcing a woman to have a child that she knows she cannot take care of is unconscionable. So I think health system should supersede any ideological, political concepts. Samantha is saying that many articles cite insufficient tools for measuring progress as an issue for health and development. How do you propose to improve health-related indicators for countries with extremely difficult setting for data collection, such as in sub-Saharan Africa? So this question is exactly, on the cutting edge of what many of us are thinking about. How can you, in countries such as sub-Saharan Africa, where there is very poor infrastructure, barely, there are places, especially in the remote rural areas like the ones that we work in. We chose the particularly difficult areas within the 10 countries of sub-Saharan Africa, and we chose very poor countries, and within those very remote and despondent regions of those countries where the indicators really were the worst. And so in those areas, there really was no electricity, roads, clinics, schools, water, etc. Certainly no doctors, sparse nurses. So how do you, in that context, in addition to everything else that's needed, how do you, in that context, develop a system of data that informs what you're doing? And that's where, if you had asked me 10 years ago, I would have tried to divert the conversation to something else. But now that we have smartphones that are affordable, well within that budget that I told you, $40 per capita, that the smartphone is affordable. Applications are now made so easy for people who are just barely literate. You actually can now collect data that inform the performance and the management and the supervision of that health worker, and can also give data about what's going on in the community, such that if in Liberia they would have had what we proposed, certainly somebody would have noticed that the community health worker is inputting fever and bleeding and death, more than the usual baseline level of those kind of deaths. And so Ebola would have been isolated right then and there, because the first few cases would have been identified and inoculated or quarantined. So it is doable now, and it's only thanks to mobile health and all the applications and the quick and easy training that we have learned is doable by community health workers. No need for any high-level educators or health practitioners. Giancarlo is saying, how can behavior change be addressed in order to reduce some diseases without being invasive in terms of cultural diversity? Boy, is this a clever question, obviously showing knowledge of how difficult it is to really provide health in any community, rich or poor, without being invasive or even resented by the community. Let me first say that the behavior change aspect of the interventions, which is a critical one, sanitation and hygiene, starts with hand washing. Hand washing is critical to ending the high incidence of diarrhea, which is a very high cause for death. And hand washing is one of the main behaviors that can really improve incidence of diarrhea. But a couple things. One, you can't begin to talk about behavior change to a community, as we were asked to do 10 years ago when we came to the villages by other donors. You can't talk about behavior change until they have the implements, the tools with which they could be carrying out that activity. So talking to people who don't have access to water and soap, talking to them about washing their hands before each meal and after using the toilet is cruel. So first and foremost, behavioral change has to be preceded by the necessary investment in commodities. Then behavior change directly implies has to be done by local people who are well known to the villagers. People coming in with all sorts of booklets and show and tell are, first of all, not accepted, and as we are seeing even lately, like with Ebola, are actually suspected of being the transmitters. I don't blame them. Behavior change has to come from within, as cliche as it sounds. So it really behooves all of us who are advising that we really rely on very good, solid, inherent mechanisms that already exist in the villages, such as schools. Have the teachers make one part of the curriculum be, let's say, since I picked sanitation, let sanitation be part of the curriculum, explain about germs, explain about diseases, etc. Very good way of teaching children, who then go home and presumably teach us, the parents. Use the chief leader, the leader in the village. Usually, quite often, at least in my experience, have been remarkable men. I understand perfectly why they have been chosen in most cases. And if you explain to them and if they embrace the concept, they can be incredibly powerful. Imams, priests, any person of authority in the village, and also neighbors. So for instance, Ethiopia has a very cleverly, on no budget, done something called the Women's Army, I think it's called, Women's Development Army, where they just train kind of a model household head, typically a woman of a household that is doing quite well, teach her to become the trainer for the other households, to show to the other women, what's the best way to cook the food for the babies, what's the best way to keep the household clean, etc. So it is very easy to be invasive and intrusive. It's the one thing that we absolutely were adamant about avoiding. For instance, in our project in the Millennium Villages, we do not come in preaching, poking, advocating, lecturing, demanding, conditioning, not at all. We came in first and foremost and sat down and listened, asked a lot of questions, listened. And by listening, what's amazing is that you not only hear what people need and want, but they also will tell you what can be done if they only had a little bit of help. So most of my learning is actually from from the village. I just want to make one quick point about behavioral change, though, that people often think that there are certain things that people will not change because they're culturally unacceptable. I have learned through the Millennial Villages Project and others that actually cultural acceptability really can change if people see the point to it. So for instance, when we started doing the verbal autopsy, which is asking the next of kin a week after or 2 weeks after somebody dies in the household, when we started asking them what were the symptoms and what did you do and what happened and was there a car available, we were told, in Malawi is where we started this, we were told, go home. Do not ask these questions. Nobody will talk about a dead child or a dead mother. It's a taboo. It's traditionally absolutely not. And so we didn't. We went to, before leaving, before throwing away that project, the verbal autopsy, we went to the chief, explained why we wanted to do it. He completely embraced it. And it got to the point where we were only doing verbal autopsies for children under 5 and women of reproductive age, because those are the ones we wanted to really impact on. We didn't do deaths, verbal autopsy on the other deaths. Within a month, it got to the point where we were taken to task for why didn't you come to my household, because my aunt died, and nobody cared. Nobody came to ask me how it happened. So just a point about cultural sensitivity, absolutely, but also be flexible in terms of understanding how communities live, work, learn, and evolve. Do I have time for another question?
I don't think so. It's 9:15.
Oh, 9:15. Sorry. Anyway, it really has been a pleasure. I would, of course, prefer that I was not only with my Columbia University lovely cohort of students who I've been with before, but that I would be able to be with you in your classroom in the country that you're in. I can only assure you that Jeff and I and Ranu and Glenn Denning and others think about you, talk about you, advocate for what you're doing, because you are really the professional generation that's actually going to make the difference. I know that for a fact. I'm seeing it already in many instances. I'm seeing it from your predecessors from this program who've gone out and done unbelievable things that are teaching us and advancing the agenda. So it really is an honor to be with you, because you are the people we do look to and will continue to look to help provide the solutions. So thank you.